I am going to be the tech support for today's event. You'll see in the chat, I've put some information. If you need to, please send me a message if there's anything that you need throughout today's session. And I am going to hand it over after a couple of our introductory slides to our team for today's presentation, including Cherie and Dr. Lucy Johnstone. So as you see on this front slide, but we're just going to jump into a couple of our pieces of housekeeping that we do from the beginning. So for today's event, participant microphones will be muted at entry, but you'll be able to unmute during our discussion portion of the webinar. So if you have any questions as you go throughout today's event, please put them in the chat and we'll collect those, and be sure to give some time during that question and answer session, which will follow the presentation. Closed captioning is available. You can click the closed captioning, a lot of C's there. Click the closed captioning button so you can select that as an option. And the session is going to be recorded and will be placed on the MHTTC website within 24 hours at the close of today's presentation. Oh, the presentation got ahead of me. Okay, information about certificates of completion will be sent out in a follow-up email. And if you have any questions, like I said, please use the chat. And if you have any questions after the session, you can feel free to use newengland@mhttcnetwork.org to reach out to us with anything that you'd like to learn. We'll be sending out a follow-up with the recording, like we said, slides from today's presentation, as well as additional resources that we've gotten from Dr. Johnstone. So that will be coming out following today's session. So again, thank you so much for joining us. I see a couple folks sharing in the chat where they're coming from. Please feel free to let us know. It's good to see people from so many different places, from Virginia, Utah, Connecticut. Love to see it. We'll start by just letting you know that this MHTTC event is sponsored by the Substance Abuse and Mental Health Services Association, otherwise known as Administration, otherwise known as SAMHSA. So anything, all material in this publication, except that taken directly from copyrighted services, is in the public domain, and that the information might not necessarily be the opinion of SAMHSA. As well, just as we're going through setting some expectations for today's event, the MHTTC network uses affirming, respectful, and recovery-oriented language in all activities. That language is strengths-based and hopeful, inclusive and accepting of diverse cultures, genders, perspectives, and experiences, healing-centered and trauma-responsive, inviting to individuals participating in their own journeys, person-first and free of labels, non-judgmental and avoiding assumptions, respectful, clear, and understandable, and consistent with our actions, policies, and products. And I'm sure you'll see that reflected in the power threat meaning framework that we are going to be going over today as well. And lastly, as a committed ally, New England MHTTC recognizes that the New England area is home to the ancestral land of many Native tribes, and consistent with their values of community inclusion, we acknowledge that all places our distributed staff live and work, as well as where we provide services and hold events, are Indigenous lands. Myself, I am calling in from Nipmuc, Pecumtuck, and Wabanaki Confederacy land in Western Massachusetts. If you are curious about where you are located, I'm going to put in the chat the website that you see in the image, where you can check and see where you're located if you don't know already. So always a good opportunity for learning as we are on land that was colonized. So I am going to hand over the mic and the video to Cherie, who's going to introduce us to today's presentation. So thanks so much for joining us, and Cherie, take it away.
Thank you very much, Lee. Welcome, everybody. I'm so glad to see people from all over.
You're muted.
It's not working.
I can hear you.
You can hear me now. Oh, great. I was going to say it's unmuted. I didn't want to be that person, but here I am. Welcome, everybody. Thank you very much, Lee. And I'm so glad that people are joining us from a variety of places. Great that you are here. My name is Cherie Bragg, as Lee said, and I work at Yale Perch, which is the Program for Recovery and Community Health. And as part of that role, assist with New England MHTTC activities. I'm a social work student, and I'm also a person who experienced childhood trauma. I was first introduced to the Power Threat Meaning Framework through the Upward Spiral Peer Support Summer webinar series. That's a mouthful. A couple of years ago when Dr. Johnstone joined us. And what I liked most about it was that it provided me with the choice of using a different lens to look at my experiences through, which meant that I could think about the meaning I made from those experiences rather than relying on the perspectives that the mental health and other systems assign to it. So with that said, Dr. Lucy Johnstone is the co-lead creator and part of the larger team in the UK that collaborated to create the Power Threat Meaning Framework. And it is with a great pleasure that I introduce you all today to Dr. Johnstone.
Lovely to be here. Thank you. So are we going to do a quick poll, Cherie? Is that the next thing that happens?
Oh, yeah, my emails. Yes, I believe Lee is going to.
Aha. What is your role?
Yes, if people can just pick which role, and there might be multiple, you can select multiple. That's fine, just to get a sense of who's here today and what roles you are representing. Thank you. And Lee, if you would be able to share the results when they come up.
Totally. Yeah, it looks like we've still got a couple folks to share. So please take your time now. If you aren't able to answer it in this time frame and you've got something else going, no worries. You can put it in the chat later. Oh, did we get a cat appearance? We almost got a cat appearance, Cherie.
Either that or my husband taking the dog out. The
All
reason
right.
for the Northern Lights.
It looks like folks have overall answered. So I'm going to end the poll and share out so that Cherie can make some meaning of this data that we have.
Okay, thank you, Lee. All right, looks like we have people from a variety of roles. About 22% are family members. 35% are people with direct lived experience with mental health addiction or trauma. 13% are paid peer support providers or other paid lived experience roles. 17% serve in volunteer peer support or lived experience roles. 26% are other mental health provider roles, working with children and families. 22% other mental health provider roles with adults. We have 4% education staff, 13% higher education staff, and 17% coming from state government or other federal government roles, and then 22% other. So as many roles as we covered, there are far more to share. So a wonderful, diverse group here today. Thank you. And I'm handing it back over to Dr. Johnstone to get started.
Thank you very much for the introductions. Really nice to get a brief sense of who's here. And it's a mixed audience, lots of people from different backgrounds, which is always good. I hope we'll be able to have some interesting thoughts and discussions. So the most difficult bit of the whole thing for me is working out to share my screen. I'm really not good at technology. If that bit goes all right, we should be fine. So I'm now going to click on share screen. Lee can tell me if that's the wrong thing to do, but I think it's the right thing to do. Okay, so I can see that full screen. Can other people see that full screen? Oh, excellent.
Perfect.
I'm going to try and move it. Advance. Aha.
Looks great.
Yes. Okay, so far so good. Excellent, thank you. Okay, so I will kick off. If by any chance I become inaudible or something terrible happens to the slides as we go through, I'm sure either Lee or Cherie will let me know. So lovely to be here with you. There's a couple of things I always say before I do presentations. One is that some of the slides have quite a lot of information on them. Please don't set yourself the task of reading every word and absorbing all the information. I tend to see slides as a kind of resource, so you could have them afterwards. I will highlight the most important bits of every slide. And my intention really is to give you a general impression of the framework. And if you're interested, there are lots of resources to follow up afterwards. If you're not, that's fine. But just kind of go with the flow. It's not meant to be bombarding you with more information than you can take in. And the second thing I always say is that I'm going to present some ideas which are probably quite challenging to some people. They're intentionally challenging. One of my main aims in life, what I like doing most, is kind of training sessions which encourage people to think. The direction in which you think is entirely up to you. So everything I say is optional, everything is up for debate, everything comes with a message of, you know, decide for yourselves whether or not you want to take this on or not. So I hope, as I say, this will stimulate some, at the very least, stimulate some thoughts. And if that is what happens, that I will have achieved my aim to stimulate some thinking. So I'm going to introduce you to a major project called the Power Threat Meaning Framework, and I'm going to show a couple of slides to set the background, if you like. By the way, I'm going to be talking till shortly after 1, and then we'll have 25 minutes or 20 minutes, I hope, for chat. And please put questions in the chat as we go through, because I won't stop to take questions as we go through. So here is a recent report, well, 5 years ago, 6 years ago, from the United Nations. I've highlighted some quotes from it. Diagnostic tools continue to expand the parameters of individual diagnosis, often without a solid scientific basis. We've been sold a myth that the best solutions for addressing mental health challenges are medications and other biomedical interventions. Those are very challenging statements. They're really questioning the whole way we currently, in westernized countries, understand what I would prefer to call mental distress and emotional suffering rather than mental illness. And the United Nations report is building on, I think also signposting and adding to a very big, what you might call a paradigm shift, a very big shift in the fundamental way we understand human emotional suffering and distress of the type that often gets labelled an illness or a disorder. And among their recommendations, they are saying we should look much more at social determinants, what's going on in people's lives, in other words. We should move away from seeing people as suffering from individual disorders that somehow arise within themselves. We should be talking about the power imbalance rather than the chemical imbalance. In other words, wider social factors, not our guesses about what may be going on but has never been proved in people's brains. So that very much sets the context for the framework. There's a follow-up report that came out only last week from the World Health Organization and United Nations, saying very much the same kind of thing. Mental health and well-being are strongly associated with social, economic and physical environments, as well as poverty, violence and discrimination. However, most mental health systems focus on diagnosis, medication and symptom reduction, neglecting the social determinants that affect people's mental health. So again, signalling quite a profound change in direction, I think a very necessary and welcome one. And I think to a large extent, this is common sense. You know, we know that people who end up in mental health services very often have difficult, troubled lives in terms of their relationships, perhaps particularly their early relationships, and in terms of their social circumstances. I think it's very fair to say that those are too often neglected. The framework actually wants to go further this and say, not only do we need to pay more attention to those factors, we need to drop the diagnostic model. Now, I'm not expecting everyone in this room to agree with me, but if you could bear with me, I will make the best case I can for that. So the Power Threat Meaning Framework, the main authors are in the top paragraph. I and Mary Boyle are both psychologists. We are the lead authors of the framework. The other people in that same paragraph are psychologists and survivors, is the preferred UK term. Eleanor Longden and Jackie Dillon are quite well-known survivors of the psychiatric system who found it unhelpful, who managed to escape from it and are now internationally known researchers, activists and campaigners. And as the project went on, we drew in a number of other people, about 1/3 of whom had personal experience of receiving mental health interventions. So the total project group was about 40 people. And it took 5 years for us to put together our collective thoughts about if we want to move away from a medical understanding of distress, if we want to move away from this very deeply, deeply embedded idea that people in all forms of distress are suffering from medical illnesses of some sort that need diagnosing and perhaps mainly treated with drugs, what would the alternative look like? The framework is our best attempt to outline what that alternative might look like. And if you're interested, and you'll get these links afterwards as well, that is the main website. There's lots and lots of material on there. There are the main PTMF documents, there are podcasts, there are interviews, there are examples of good practice, there are videos, there's a list of the research that's going on into the framework. There's more than you would possibly want to know about the framework, probably. Anyway, it's all there for you to enjoy should you wish to. And it's all free, and this is part of the general principle of our project, really. This is not a money-making enterprise. This is not about setting up expensive training programs or selling books. This is about free knowledge, if you like. It's about spreading different ideas. You can download the PTMF documents for free from the website. Probably won't be completely free by the time you've used up all that paper and ink, or you can read it online. You can also get at cost price copies from Amazon.com. So I will warn you that the main PTMF documents, this is one of them, and there's another one called the main document, are quite dense and academic. They're not an easy read. Now, in a way, they have to be dense and academic because we wanted to ground them as solidly in evidence as we possibly could. But on the website, you'll also find lots of much more accessible versions, shorter versions, videos, interviews, and so on. And although I said it's not about selling books, there is a book. So Mary and I have jointly authored this book, which is also available on Amazon, which is the nearest thing to a description of how you might use the framework with someone you're working with or supporting, or for yourself, because we very much do not believe there is some hard and fast line between people who are said to have mental illnesses and disorders and the rest of us. We all struggle at times. We all experience distress at times. So this, if you're interested, is a kind of step-by-step guide, if you like, to thinking about whatever struggles you or perhaps someone you're working with or supporting may be going through, and how you might adopt this perspective and perhaps find some new ways forward. So that's the resources and materials, more to come. So, as I said, it took 5 years to produce the framework. It was published by the British Psychological Society, which is my professional body, but it's not an official BPS model. Psychologists in the UK don't have to use it. A lot of them don't particularly like it, and that's fine by us. And it's not saying stop everything you're doing and do this instead. It is saying there's already a great deal of good practice out there, which I'm sure a lot of you are aware of, probably involved with yourselves. It's saying what we want is much more support and evidence and validation for that existing good practice, which isn't narrowly diagnostic based. But we actually want that to be the default model. We don't want it just to be a case of you might be lucky enough to come across it. And we also hope that the framework adds additional possible ways forward. It's not just about use in services. As I'll show you, there are people who've used it in peer groups and other non-service settings. It doesn't tell you in any detail how to do it, so to speak, because it's basically a set of principles. We wanted to draw up a set of principles for a way of understanding distress, which is not based on the assumptions that we're all told about, the medical assumptions. And we wanted very much to leave it up to individuals, if they're interested, or particular services or teams, to say, how might these principles work in our setting? And we wanted people, if they're interested, to do some evaluations, to tell us how it worked, to feed back to us, so we can put that on the website. So the process of moving forward with the framework and developing it further is very much a kind of co-produced, co-developed one, if you like. We supply the principles. You, if you want to, supply the examples in the areas in which you are experts. We together move forward and develop the framework, as we go forward together. It's proved remarkably astonishingly popular. When we launched it in 2018, after a very, very long and stressful and hard work period, lots of times thinking, what the hell have we agreed to do, and why have we agreed to do it, and what on earth is going to come out of this? We weren't even sure if anyone was ever going to be interested. Will a single person ever read it? We thought. Well, much to our surprise, it's currently being translated into 8 languages. Seminars and workshops have been developed in person and online in 18 countries, some by me, but there's a group of us doing that kind of work together. It's pretty well known in the UK, but even in the UK, it's still very much a minority approach. But I will show you some examples of where it's taken hold. Nevertheless, I think its popularity does suggest there is widespread dissatisfaction, not just in the UK, with the way we currently approach distress, the poor outcomes, the fact that some people seem to be made worse by services, the fact that levels of distress seem to be rising rather than reducing. I think there's a widespread feeling that there's something we're doing just not quite right. So is it evidence-based? I thought I'd briefly address this because I noticed the MHTTC network is very keen on evidence-based stuff, which of course is important. We would like to claim it is. It's based on a 2,000-word, 5-year multi-authored overview of all the evidence that we could find. The principles are based on that evidence. However, we would also want to say we take a bit of a critical perspective on what do we mean by evidence, what counts as evidence, whose voices count, who disseminates the evidence, who benefits from the evidence, whose voices are silenced and marginalised in the process. And we very much wanted to include forms of evidence that are traditionally excluded, like what real people say about their actual lives. That's just as important, possibly more important. And the second question I thought I'd briefly address, as you are partly funded by SAMHSA, is what does the framework have to say about trauma-informed approaches? You will all know what trauma-informed approaches are, I'm sure. We think this is an extraordinarily valuable body of knowledge. We've drawn it in extensively in the framework, as well as on other stuff. And we've taken a particular perspective on trauma-informed approaches, which can mean an awful lot of different things, I think, to different people in different settings. So we have very much emphasised the structural factors, inequality, social inclusion, discrimination, colonisation, and so on, which sometimes get a little bit kind of pushed to one side if we focus too much on individual traumatic histories. We've also talked, as I will explain, about patterns of distress which don't relate to obvious trauma, people who are still struggling enormously and in a lot of distress very often, but who don't fit into a classic trauma picture. We link very much to wider structures, and we are very, very particular about language. So some trauma-informed practice does use words that we don't use because to us they imply medical perspectives, which we are trying to move beyond. So we don't talk about dissociative disorder, for example, or PTSD. We don't agree with the D. And that may or may not be your practice, but it's ours because language shapes the way we think. And if we want very different ways of supporting people, we need to mind our language. Okay, so what does the framework say we should use instead of diagnoses? In the briefest possible form, it says we should use narratives instead. The framework believes we are all storytellers and meaning makers. We support the use of all kinds of narratives or personal stories instead of diagnostic labels. This, we think, allows people to create new non-medical hopeful narratives about their lives and circumstances, instead of seeing themselves as mentally ill. And you will be familiar with this slogan, I'm sure, the shift of perspective from instead of asking what's wrong with you, ask what's happened to you. And the framework is about all of us. We mean narratives in the widest possible sense. We have something in the UK, and I think you also have it in the US to some extent, called a formulation, which is a kind of a personal story based on the evidence constructed with a professional. But in narratives, we include poetry, art, music, theatre, dance, community, rituals and ceremonies, and so on. All kinds of narratives can be a way of making meaning of our distress, of creating healing, and of helping us to move forward in our lives. And having said that, the framework suggests, this is all 100% optional, of course, suggests a particular way of constructing or co-constructing narratives, which may be helpful to some people. So we have taken that question, instead of asking what's wrong with me, ask what's happened to me, and we've expanded it into these 4 areas. What has happened to you? The first PTMF core question. In PTMF terms, how is power operating in your life? How did it affect you is the next question. In PTMF terms, what kind of threats does this pose? What sense do you make of it? In PTMF terms, what is the meaning of these experiences to you? What did you have to do to survive? In PTMF terms, what threat responses are you using? And you might want to add or start with what are your strengths and pull it together into what is your story. Now, this really isn't some new formal assessment schedule where you have to get out a pen and a piece of paper and tick off the questions. These are rough ways of structuring an ongoing discussion. You can start at any point. The questions are overlapping. You can't really talk about power without implying meaning. You can't really talking about threat without implying threat responses, as we'll see. And you don't have to use those words. If those words sound a bit off-putting to you, think of different ones. But these is a possible way of thinking and creating narratives at all sorts of levels: individual, couples, families, which many of you will be familiar with. That's part of your area of work. Families can have their own stories, of course, and individual members within that have their own particular narratives, the roles they take in the particular family, communities, whole cultures, and so on. So I'm going to go through this briefly. As I said, please don't try and read all this detailed stuff on the slide, because you don't need to, and there probably won't be time. But in essence, what we've tried to do is consider a very wide range of power influences which operate in all our lives to some extent, and can operate negatively for people who end up, suffering various forms of distress. Power is not intrinsically bad. Power is neutral. Any of us who are professionals here have acquired power through our training because we want to help and support others. But power can be misused, and typically the people who end up in distress and in services have been on the receiving end of negative use of power, probably in many or perhaps even in all of these areas: legal, economic, material, interpersonal, which the trauma-informed work picks up on very strongly. I think the various ways people can, in their relationships, hurt and abuse and neglect and exclude and marginalize and undermine and criticize and invalidate each other, and so on. The power associated with our bodies, coercive power, which of course overlaps with other forms of power, social or cultural capital, the kind of things that accrue to us, often unearned privilege, if you like, through perhaps, speaking of myself here, being white, being middle class, and so on, being able-bodied has given me a lot of advantages that aren't shared by everybody, and ideological power, which I'm going to come on to in a minute. So in all our stories, we need to think about the role of power. And why is this so central? Well, we wanted to put it up first and foremost because it seemed to us that a consideration of power is what diagnosis automatically excludes. If you start thinking it's my chemical imbalance in my brain, then we're locating the source of your distress very much within an individual and perhaps in your brain chemistry. Similar kind of individualizing perspectives are taken by quite a lot of psychology and psychiatry as well. So it's not saying psychiatry bad, psychology good. A lot of psychological approaches are, we think, much too individualizing. But actually power is everywhere in our lives. And although we sometimes act as though we don't know about the causes of distress, and we pour millions of pounds and dollars into new research programs and so on, we know such a lot. We have an overwhelming amount of very solid evidence about the primary causal factors in distress. We've summarized this in the main PTMF document, and they all involve inequalities of power. They're to do with being poor. They're to do with living in unequal societies, of which the UK and the US are, I'm afraid, prime examples at the moment. They're to do with abuse and neglect. They're to do with gender-based, race-based discrimination and violence. They're to do with colonization, war, and conflict. And all of these set up power differences between more and less powerful groups of people. And all of that tends to lead to, understandably, various forms of distress. Okay, so when we focus on power, it's much less to switch back into individualized understandings and versions of models of distress, because if we think about power, we are almost automatically linking the personal and the political, linking distress to inequalities and social injustice, linking the various factors that contribute to distress, making distress understandable instead of just saying it's her mental illness or whatever. Help to restore agency, help to give people back some better sense of control in their lives, even if realistically there will always be areas that are not under your control. So that's one why we need to think about power. And we particularly need to think about ideological power, which we've defined as control of language, meaning, and perspective. This is slightly more difficult to get our head round. It's to do with the automatic assumptions we make and are taught from our earliest years, our worldviews, the things we take often without thinking as natural and desirable and good or bad and undesirable or abnormal or whatever, the standards we feel we should live up to, the things we think we should avoid, the way men should be, the way women should be, the stereotypes we hold about particular groups in societies. All of these messages come at us all the time from all around us, our friends, our families, our educators, the media, and so on. And these messages are sometimes used quite cynically, I think, by powerful people to sell certain social and political and economic policies to us. We have a very good example, I'm afraid, in the UK with Brexit. As you will know, we decided a number of years ago, must be 5 years ago now, 6 years ago, to exit the European Union. It's been an absolute disaster. This policy was sold to us very much through the use of language, through lots of horrible rhetoric about immigrants who were going to flood our welfare systems, through lots of other rhetoric about becoming Great Britain again, you know, reclaiming the position we had during the era of the British Empire was the kind of implication, horrible stuff. And actually by feeding into people's fears and quite unrealistic aims and ambitions, we were able to bring about a change that has massively benefited more powerful, wealthy people and massively discriminated against just about everybody else. We now have food banks and homeless people on just about every street corner. So that was an ideologically driven policy. But ideology appears in all sorts of places, and we would argue that it is used in mental health services and the criminal justice system to individualize problems, to label the results ultimately of social policies as individual problems of madness or badness. And we would also argue, controversial statement coming up, that imposing a psychiatric diagnosis, these are known not to be scientifically valid categories. Telling someone as though it's an established fact, you have a bipolar disorder, you have a personality disorder, you have clinical depression, etc., without making clear these are contested, controversial categories, without offering alternatives, is an example of injustice. Okay, we can come back to that. I think I'll say at this point that we actually take a position that, you know, we don't want to impose our understanding on people either. We think it's only right that people have a choice. If people find those labels helpful, and in the diagnostically based world we live in, they are sometimes necessary. We fully acknowledge that. They may sometimes be very necessary for access to services and benefits. That is fine. But that's very different from an expert imposing a version of reality with all the power that they have, which has very significant impacts on people's identities, futures, and entire lives. So I'm going to go through the next questions rather more briefly. As soon as you start thinking about power, you automatically start thinking about the threats. The misuse of power leads to threats in all sorts of areas of our lives, some of which we're used to thinking about, some of which we're less used to thinking about. So there's some areas, relationships, emotions, links to the social and community and economic and material threats, environmental bodily threats, and threats to our value base and meaning making. We're coming round in a circle again because you can see these are overlapping questions. It is a significant source of distress, we think, when people are not allowed, not encouraged, maybe actively discouraged from making their own meanings about their lives. A very concrete example of that might be someone who says, I haven't got schizophrenia, and may end up being held down and injected. That's a pretty brutal imposition of a particular set of values and meanings. But there are much more subtle senses as well, which leave us, I think, all of us at times feeling quite unnecessarily inadequate about our lives, our choices, our achievements or lack of, and so on. We are much less encouraged to question those standards, I think, than we should be. What sense did you make of it? So meaning is the core thread through any narrative. Meaning is very important. Any therapist in the audience will know that all therapy is fundamentally about creating or co-creating or changing meanings. But we very much wanted to take meaning beyond a rather individualistic understanding, which is quite a common one, about sort of tweaking your negative cognitions or whatever the latest rather narrow version of CBT might be, because actually meanings don't come from nowhere. Our meanings don't arise, don't pop up in our heads separate from the environments we live in. Our meanings are shaped by common understandings in society around us, as I've already said, about what it is to be a happy family, a good mother, a normal child. All the families you work with will have taken on board, not consciously at all necessarily, and you will too, and we all do, all sorts of meanings about being a good mother, being a happy family, being a responsible dad, being a normal child, and so on, which may be helpful, may be unhelpful, too often go unexamined. But it's particularly important for us as professionals to pull out and examine those assumptions, I think, because otherwise we risk kind of perpetuating them, reinforcing them in ways that may be unhelpful for the people we work with. So that's meanings. Okay. And what did you have to do to survive? This is kind of the area of trauma-informed practice. So this will be familiar to some of you. We use the term threat responses or survival responses instead of symptoms. Or all the experiences that typically get labelled as symptoms in mental health services, we would say, can be understood as threats, as responses, and understandable, ultimately, responses to the threats imposed by power. And they're on a spectrum, and they involve our bodies as well as our minds. The framework, like trauma-informed practice, is about our bodies as well as our minds. They're inseparable, they're very closely linked. So emotionally overwhelming situations, as we know, affect our bodies, may leave us in a state of hyperarousal, of terror, of distrust, and so on, as well as affecting our minds. And these threat responses, we would say, and trauma-informed practice would say, they were necessary at the time. They helped us to survive. We come, let's say, from a domestically violent context, being hyper alert and vigilant helped us to survive at the time. But if those threat responses continue when they're no longer needed, they can become very problematic in their own right. As the saying goes, we may continue to live in trauma time even after we're in a safer place. So some examples of threat responses, with the top ones being ones that we typically experience as being less under our conscious control and more kind of bodily based, and probably less invariant across cultures, because as members of the same human species, we all share certain kind of biological ways in which our bodies react to threat. But as we go down the hierarchy, we can see things that may be more culturally dependent. Eating distress is much more common in some cultures for others, for example. And right at the bottom, we may see things that perhaps are not healthy behaviours, but because they're socially valued, we're unlikely to get labelled and medicated for doing them. So that's me at the bottom, overwork and perfectionism. We're all encouraged to work too hard. We're all encouraged to live up to unrealistic standards. I'm very aware that sometimes I fall into that trap. But, you know, as I said, nobody's going to see that as a sign of a mental illness, because that's what we are, I think, all quite unrealistically pressurized to do nowadays. So a main purpose of the framework is to restore the link between threats and threat responses, or to put it another way, put back the links between personal, family and community stress and social injustice. when we apply a diagnostic label, when we say it's your psychosis or it's your depression or it's your anxiety disorder, we lose that link. We somehow focus in on the individual, we lose their context. And this is a very odd phenomenon, I've always thought, because at one level, putting back the links between the threat responses is common sense. If you asked any person in the street, do you think people living in poverty are more likely to be miserable and distressed? They would say, yes, I'm sure they are. But as soon as we know that, we start translating into different language and different concepts. We start saying things like there's an epidemic of depression and this magic pill might cure it. I mean, it's a very odd way of thinking, I believe. So the aim of the framework is to put those two things together in a way that it's difficult to pull them apart. But that's not easy. It's really not easy, because actually the links are sometimes obvious, like the ones I've just given you an example of, but actually very often it's a more confusing picture. So we get people who come into services with a whole range of different behaviours and experiences, which on the face of it may seem kind of bizarre or frightening or, you know, very hard to understand or very unusual. We often don't know people's whole histories. We often don't ask them. They may not be fully aware of the whole histories themselves. There's all sorts of ways of confusing the picture. The pressures may be more subtle, what we would call ideological pressures, just a general feeling you're not good enough or you're not worthy enough or that you don't fit in society. And if we're coming at all this from a diagnostic lens, we are kind of at risk of blinding ourselves as well as unintentionally, I would say, blinding others by hunting for the label, if you like. So it's not easy to make those links, but I think we have to make those links. And I think we have to make those links outside services too, in society as a whole. Why are we seeing rising levels of distress? Well, because of links that we don't actually want to make as a whole society. So I'm going to show you a couple of examples. We've had a lot of this kind of stuff in the UK press recently after COVID. Apparently there is a tsunami, a tidal wave of mental health problems. We had not just one epidemic, but two. We had the deadly virus and now we've got all the mental health problems. As though they're somehow disconnected. That's just an unfortunate coincidence, one epidemic straight after another. But actually, if you look at the research, it shows that the people who are said to be suffering mental health problems post-COVID are those who were having a much harder time. They're elderly, isolated people, they're burnt out frontline workers, they're people who were financially very insecure. Almost all minority ethnic groups had higher risks of dying from COVID than the white British majority of a comparable age. What COVID actually did was expose massive levels of inequality in our society in the UK. What the moral really should have been is that society needs to be fairer and more equal, not just to protect us against COVID and mental health problems, but to protect us against all life's adversities. That is not the moral that's been drawn from the situation. Instead, we've seen, I think, quite cynical calls very often from lots of professional groups saying we need hundreds more doctors and nurses and clinics. And while mental health resources are always, can always do with more funding and more people on the ground, that's not fundamentally the answer to the problem that was exposed by COVID. So I wrote this article putting a rather different point of view. In ordinary language, people with more to be exhausted, depressed and anxious about are feeling more exhausted, depressed and anxious. However, it is not a pandemic of mental health problems we need to fear, but a pandemic of mental health thinking. If we think in diagnostic terms, we won't see the problem and therefore we won't apply the right solutions, which of course are complex, ultimately social and political solutions, which a lot of people don't want to think about. Okay, much easier to blame the individual or ascribe it to a mental health problem. Here's another example. There was a recent piece of research showing that 17 to 19-year-olds in the UK, a quarter of them have a probable mental disorder, which doesn't sound good, does it? And no doubt these people, I don't doubt these young people are feeling very unhappy, but if you look at the research, it shows that the unhappiest young people were more likely to be being bullied, feel unsafe in school, lack friends, be worried about exams, and come from families that are really struggling, can't afford food, can't afford to pay the rent, can't afford to heat the house. They didn't suddenly develop a mental disorder, these young people. They were distressed for very understandable reasons. Put back the threat and threat response links, and you can see that. Okay. I'm going to look briefly at a couple of other aspects of the framework. So you're doing very well so far. Thanks for hanging on in there. So we've made an attempt to construct not just or to suggest how to construct one-to-one narratives or family narratives, but narratives that work at a bigger level, perhaps at the level of a whole society. And we've done this by drawing on a whole range of evidence because, as I've already said, the personal narratives we construct about ourselves don't come from nowhere. We pick them up from wider stories in society, how women should be, how men should be, what we think of people who are refugees or who are a particular ethnic group or have faced particular circumstances. So we've made an attempt to outline what those broader narratives might look like. So the broader narratives feed into the individual narratives feed into the broader narratives. There are always individual aspects to a personal story, but there are also always common elements. And by putting this together in these broad patterns, which of course are always changing and evolving because societies change and evolve and meanings change and evolve, we hope we've created ways, firstly, keep putting back the threats and threat responses. Secondly, to help people construct their narratives by being able to look at a pattern that says, in effect, your experiences are so common that there's actually a pattern that may, broadly speaking, describe it, which may give people some of the benefits that they say they get from diagnosis, the sense it's not my fault and I don't have to feel so guilty and I'm not the only one who feels like this. Well, those are very real benefits, but diagnosis comes with disadvantages, and we think the patterns might be a better way of doing that. So I'm going to show you a couple of examples. This is an extract for one of our patterns that's called surviving poverty. Many of you will be working with families who are living in poverty. And if you go on the website, you can see these list of patterns. And there's an awful lot of research about general effects of living in poverty. It won't apply to every single person who lives in poverty, but generally speaking, there are power aspects to living in poverty that affect access to every part of your life, as you can see listed there, and create threats to almost every area of your life that often result in feeling overwhelmed, shamed, humiliated, controlled, defeated, trapped, and so on. And that may, for reasons that actually, when you unpick them, be very understandable, encourage people to misuse alcohol and drugs, to feel anxious, to find it hard to concentrate in school with their children, and so on. So I hope you can see that a kind of pattern of this helps us at all sorts of levels, as workers, as people who may live in those circumstances, ideally at a societal level as well, to think, well, it's not surprising. Poverty has devastating effects. While it may be of some use to have, public health programs telling people to drink less, everybody knows drinking too much isn't good for you. But if you look in this context of this pattern, some people have very few available choices to manage their very difficult lives. We actually need to look much more at the root causes rather than implicitly blaming the person for their overuse of alcohol. Okay, there's some more patterns that are on the website. One of them, surviving spiritual crisis. Another one is a pattern that applies very broadly to a lot of young people. As I said, the evidence-based patterns, the one about children and young people, draws heavily on the work that was done in 2005 to propose a new DSM-4 category, and we've kind of rewritten it without the disorder. So these are evidence-based patterns, we would argue. Okay, I'm going to briefly look at another aspect of the framework of what we might call culture. One of the more regrettable aspects of diagnostic thinking, in our view, is that our diagnostically based model is being exported across the globe to cultures and countries and to groups within westernized cultures that have never traditionally had it and, in our view, don't need it. And the framework takes a very different view that we should be encouraged to respect and learn from local indigenous ways of understanding, expressing and healing distress, which interestingly are often narrative-based and community-based. And I notice you have networks that are very much to do with working with Native Americans and so on. So I know you're very aware of these important differences. So I'm going to give you a tiny example. I was lucky enough to go to do a tour of New Zealand with the framework, and I did a workshop in New Zealand I asked if there could be some people present from New Zealand's indigenous people who are the Maori, and I presented the framework on the first day, and on the second day some Maori elders and people presented their understanding of distress, which of course was very, very different. I had lots of PowerPoints. They had lots of communal singing and stories of their ancestors and so on, because interestingly, Maori understandings, in common with many indigenous understandings, are community-based, narrative-based understandings. They're to do with the Sky Father and the Earth Mother and the gods and their interactions and their conflicts and their triumphs and so on. They're very, very different, but as the 2 days proceeded, we realised that in some kind of quite profound sense, we were both talking about narrative understandings, very different narrative understandings. Maori were talking about narrative understandings that made sense in their cultural context, and I was talking about narrative understandings that made much more sense in my context. But this was a process of respectful learning from each other, not a we have this special westernized knowledge which we're going to impose on you. So I was interested to meet a Maori psychiatrist, and she described to me how the existence of the framework had supported her argument to set up clinics which are based on Maori understandings of distress, of which there are a couple in New Zealand. It's a very enlightened place in lots of ways. So you can go along and request an entirely Maori understanding of distress rather than a diagnostic medical one if you want. And it wouldn't be just you, of course, because it'd be your whānau, your extended family, and it'd be sitting down with a group of people, and it'd be sharing stories, and it'd be a very, very different way of understanding distress. Now, this psychiatrist is not explicitly using the framework in that clinic because she doesn't need to. They have their own understandings, but the existence of the framework encouraged her to argue and supported her to argue for space to use and validate and respect the ways of understanding distress that made sense locally in New Zealand. The framework has acted as a distant cousin with more commonalities than differences, she said. You can read the blog at that website. Okay, so have I missed out a slide? I think I may have, sorry. I may have missed out a slide, but anyway, the slide I missed out says that the framework places a great deal of emphasis on going beyond our traditional understandings of, beyond the role of trauma, which we all know about to some extent in this group, I'm sure, and looking at things like intergenerational trauma, loss of identity, culture, heritage and land, histories of slavery. I mean, all these kind of things, which we know about, and yet we sometimes fail to fully appreciate how the impact of this echoes down the generation. You know, it is not surprising that all Indigenous communities throughout the world, as far as I'm aware, have sky-high rates of so-called mental illness and, you know, misuse of alcohol and so on. If you had been, any of us have been deprived of our identity, heritage, language, land, families, communities, and ways of making meaning, perhaps most importantly, we would be turning to, you know, we would not be feeling good about ourselves and our culture and our community. Okay, so I now want to talk very briefly about the use of the framework. Sorry, I'm getting a bit confused with my slides here. Use in peer groups. As I said, the framework is not necessarily about professional use at all, though it can be. If you go on the website and if you look at that yellow book, you will see a number of examples of peer groups that have used the framework. There's two that came across the framework and quite independently decided they were going to meet, carry on, you know, their usual practice was to meet once a week as a group. They decided they were going to take one of the framework core questions every week starting with how is power operating in your life, and discuss it together and share ideas and see if over the weeks, as they work through the questions, that helped them to co-create different versions of their own narratives. And the facilitator of one of the groups is a woman called Amanda Griffiths, who said that she found the framework empowered her to reclaim her selfhood as she began the life-changing process of transforming from a service user labelled with a personality disorder to become a strong, independent survivor taking control of my own life. There's a number of examples of people who did this, both on the website and in the book. And this is a quote from another peer group facilitator. This is a woman in New Zealand who describes the impact of really sitting down together with peers and thinking about power, and how that can be quite profound and not always easy. The power discussions are some of the most heartbreaking but also exciting to facilitate. Heartbreaking because it can be really hard for people to suddenly experience the realities of how power is operating negative in their lives. In each group, there's been at least one person who experiences anger over the following week as they come to terms with seeing the impression in their lives. However, it's also exciting in that you can literally see people sometimes sitting up straighter. These are not easy processes. These are not pain-free discussions, and they're optional discussions, but for some people they can be profoundly transformative. So Amanda, whose quote I showed you 2 slides back, has generously shared some of her story on this slide. You can read the rest of it on the website. So when she herself was working through the questions of the framework, this is what she came up with when she started reflecting on power. Like many people, she is a survivor of very, very difficult circumstances in her childhood and subsequently, and also like many people, she ended up feeling that services had re-traumatized her. She ended up with a label of personality disorder, which she felt pathologized her, silenced her, gave her the message she was never going to recover. That was where she started. And she has also shared her responses to the questions about threats, meanings, threat responses, and strengths, but I won't go through all those. But I will show you what she ended up with. This is the story that she ended up with. I'll give you a couple of minutes just to read that, but essentially it's a story that doesn't deny any of her difficulties, but actually has room for her strengths, has room for acknowledging the good things in her life, and has enabled her to drop this identity of personality disorder and actually to carry on what she was already doing, in fact, using her very painful experiences to campaign for better care for others, which has brought new meaning into her life. So I'm very pleased to say that Amanda has joined the group of people who offer training in the framework, and she's done a lot of training, some of it too. She and I did joint training to Stanford Psychosis Unit a few months ago, so it's great to have her on board. Also delighted to hear, to say that we have a number of other survivors on the committee who are also helping us to develop the patterns, to offer training and to take the framework forward. Going to show you one other example. I won't show you, I'll whiz through some of the slides because you can have the slides afterwards. This is the biggest example to date of how the framework might change services, and it's an example from some inpatient wards in London. And again, you can have the slides and you'll be sent links to the paper that reports on these results, but I'll just briefly highlight some aspects of it. An inpatient adult mental health ward in London is not where you want to be if you're well at all, or if you're suffering from any form of distress. Typically they're very overcrowded, noisy places, underpaid, stressed staff, very little attention to the kind of care people need. And that was the situation in 2017 when a group of staff decided they were going to try and do something different and move away from a narrow diagnostic model. So they did 2 main things. One, they introduced trauma-informed practice on the ward. You will be sent a link to these manuals. They're free to use. They develop these very, very useful, impressive set of accessible manuals, which are about first stage trauma work, about helping people to gain a better sense of control over their feelings and their reactions and so on, and establish more safety in their lives, so the staff had different tools to use with the patients on the ward, if you like. So the power, threat, meaningful work tends to fit quite well with trauma-informed practice. And they also introduced a practice of constructing understandings of people's problems, not based on diagnosis, but based on the power, threat, meaning framework in regular meetings. So this shows you the structure of the meetings, in which, in relation to each service user, there is a chance to reflect on power, threat, meaning and threat responses. And that can provide a basis for better understanding for the staff and perhaps different ways forward for the patient or service user. Okay, and so I don't want to run out of time, but there are interviews from the staff saying they find their jobs much more satisfying and they have a much better understanding of people's distress and their reactions. And there are interviews from the service users saying they found these strategies helpful and they felt they've got new strategies and they felt understood and listened to. And after 4 years, there's some quite dramatic positive changes, massive reduction in self-harm, massive reduction in use of restraint and seclusion. Staff and service users both reporting higher morale, better outcomes, and a much more satisfying experience. This is my final slide, which is just to prompt some thinking, if we want, either now or afterwards. How might you apply any of this in your work? If you want to, it's entirely up to you. So a lot of the framework is not about doing anything radically different, but about perhaps expanding on your current practice. So you might be wanting to do exactly what you already do, but perhaps exploring power influences in more detail, using perhaps PTMF questions to gently open up new perspectives on diagnosis, on mental illness, and perhaps lay the foundation of new narratives. Or you might want to use the framework more explicitly. And there is guidance on the website, co-constructing new narratives using the guided discussion. There's a template that looks like that. You'll have the slides, that's the link to the template, you'll have the link. And or you might want to share the PTMF ideas more directly with clients or families via any of the follow-up resources or information on the website. And if you're not ready to do any of that, or don't think that's going to suit your practice or your life, you might want to look at more of the articles, resources, read and view the stuff we're going to send around. You might want to try out constructing your own story. And whatever you do, we'd be very happy to hear from you. That's the email address. How did it go? Do you have any questions? Do you have examples of practice? We'd be very happy to respond to questions and queries via that email address. Right, I think I'm dead on time. So I'm sorry if I had to rush a little bit to be on time, but I hope at least some of that makes sense. I'm going to stop share and then I will take some questions.
Thank you, Dr. Johnstone.
Please call me Lucy. Please call me Lucy. Nobody calls me Dr. Johnstone.
I don't know that anyone has put any questions in the chat yet. I did not see any. So maybe we can start with some of the questions that we had. Let's see.
There are some, yes, we had a discussion about questions people commonly ask. So we could start with those, and I'm very happy to answer any other questions, or it doesn't have to be a question, reflection, thoughts, challenges, disagreements. Please feel free to put it in the chat.
Great. And while people are doing that, I guess we'll start with some of the common questions that people ask, as you said. And one of those is, are you saying not to take psychiatric drugs?
Thank you. That is a common question. It's a very common question. We do have a section in the main PTMF document reflecting on the pros and cons of using psychiatric drugs, but very briefly, we're not anti-drugs, we're not anti-medication. It's clearly useful for some people. What we are anti is misleading information, and we think there's a lot of misleading information out there. So it's very common that people aren't told there are alternatives to drugs. It's very common that the advantages are overestimated. It's very common that people aren't fully told about the disadvantages. We've done a lot of campaigning in the UK to highlight, for example, the very real risk that antidepressants can lead to long-term withdrawal effects, which, you know, for some people certainly outweigh the disadvantages. So we would emphasize all that. We have quoted the work of British psychiatrist Joanna Moncrief, who you may or may not be familiar with. She's might be useful to put her website or a link in the website if you can, or to send it afterwards. She has a way of explaining drugs, which is, she says, she calls it a drug-centered, not a disease-centered approach. A disease-centered approach implies that this drug will treat the underlying cause of your disease. The antipsychotic will treat the underlying cause of your psychosis, like an antibiotic kills the bacteria that cause your infection. But she says, actually, psychiatric drugs don't work like that. They have effects which are generally maybe soothing or sedating, or may relieve us from our overwhelming feelings. They do not, in the sense in which it's usually understood, treat medical illnesses. So when you take that into account, I think it changes the risk-benefit kind of calculation. And I think it suggests very strongly that it's not necessary to be on these things long term. And if it's not helpful to you, you should say so, and you should be given a chance to try something different. That's her website. Thank you.
Thank you. I know you did mention spiritual, that the framework can encompass spirituality and that kind of questioning. Can you say a little bit more about that spiritual crisis?
Yes, well, I think I saw that one of the people watching is Anand Patney. Hi, Anand, if you're there, who is a person with lived experience on our committee, who took the lead in drawing up a pattern which is called Surviving Spiritual Crisis. So do visit the website if you want to look at that. It's, you know, there are commonalities in people's experience of going through what they would call a spiritual crisis, which sometimes is described as psychosis or schizophrenia. So we very much accept and value the fact that some people will understand their experiences in mystical or spiritual or religious terms. The framework can very much accommodate and support that. And as I said, we've outlined a pattern that may help people to decide whether that's a way of making sense that works for them, and may suggest some ways in which people have typically managed to survive those experiences, which can, of course, be very, very intense, but can also be experienced as kind of enlightening and, you know, as ultimately helping people to move forward in their lives.
Thank you. And I almost hesitate to ask this one, but has there been any criticism or backlash to the power threat meaning framework?
There has been a lot, yeah. So that's why I've come off Twitter. Actually, you could put this in the chat. Sorry, Lee, be very. It's at PTM Framework. Twitter handle at PTM Framework is the account that links to the power threat meaning framework. So if you want to follow news updates and you're on Twitter, which is generally a bad thing to be, you can go there. I'm not on Twitter as a personal presence because I'm one of a couple of the authors who were on Twitter, and it's just a very unpleasant experience, to be honest. We've had a lot of backlash, and it kind of puzzles me a bit because we've been very clear from the start. Nobody has to read this, nobody has to like it, nobody has to agree it. If you find diagnosis helpful, you are not going to find a problem getting one, or it's very unlikely. If you want pills, you'll almost certainly be able to get them. But, and I mean, it is my view that the criticisms are nearly always based on a distorted view of the framework, that, for example, we're imposing trauma stories on people and we're denying them choices, and we're actually trying to do the opposite. So I think there are many people who are very invested in this, in the diagnostic model. I mean, it's obviously professional groups, and some professional groups more than others are very invested in this model. A lot of service users, patients, survivors are very invested in this model. It becomes very part of their identity, and that is fine by us. We simply want to offer alternatives to people who aren't happy with identity and who never really felt happy with it in the first place. So it really, really is about thinking together. And of course, we're not saying the framework is perfect. It has plenty of limitations. We want to see it developing. I myself look back on it and see a number of things that I'm not so happy with now, that I wish we'd done a bit differently, but that's okay. We welcome, you know, criticism that actually is based on what we've actually said, not what people say we've said, because of course that helps us to develop.
And that sounds very growth minded. There's room for growth, there's room for change.
Of course there is, yeah.
Very positive. And as a social work student, I also appreciate the discussion about valuing the system that we have in place, and that it's of different value to different people. I've certainly kind of noticed the history of even social work moving from being out of systems and environment initially, at least here in the US, I'm not sure in the UK, but that now what's valued is that you have that clinical license, and so that you can, and things that come with that, for good or bad. So just noticing those things. I do see a question in the chat too. Anita asks, has this approach been integrated in the US Northeast region?
I can't answer that, I'm afraid. My geography is very poor for a start. I have zoomed in to various American discussions, but I couldn't tell you whether in the US Northeast. And I'm not really aware of everything that's going on. People may have picked up or may not, I don't know.
Would you say about the US in general, I guess?
Well, that's interesting. The US has been slower than some places to take it on board. Or to express an interest. So there's been a lot of interest, for example, in Denmark and Spain. I mean, that's quite near to me, obviously. Been to Denmark, 6 or 7 times, and ditto Spain. And Spain has translated all the documents, and Denmark is about to embark on the same process, and it's being used in a number of places. I'm not sure if you're familiar with the website Mad in America. I could put that in the chat or in the resources, www.madinamerica.com. So that is the go-to site for any critiques of psychiatry, mental health, alternative perspectives. It's a brilliant and expanding website. And they have done interviews with us, and they've highlighted the framework, and they've published some of the articles and so on. But I think I'm not sure how widely influential that is in America as a whole. And my general impression is that the medical model is pretty firmly embedded in America, partly due to your insurance system. And thank God we don't have that in the UK. Sorry, don't mean to be rude. but actually it gives, I personally have never had to put a diagnostic label in a box as a clinical psychologist in my whole career. And, I would refuse to were I been required to do so. But it gives us much more freedom, I think, to develop alternatives, because we're not quite so tied to insurance requirements, which are based on diagnostic categories.
Thank you. And
in relation to your comment about social work, yes, there's another social worker, Aileen, who says she wants to pursue her master's in social work. I strongly believe deeply ingrained, outdated societal thinking and systemic discrimination and oppression impact individual mental health and well-being. I so much agree, and it's the same as in the UK, actually, that social workers, I think, start off with that perspective. This framework's been very much welcomed by a lot of social workers who have said, this is what social work is about, or at least it's what it used to be about. Social workers know this stuff. So from a social work point of view, it's not telling you anything new, I'm sure, but it is trying to say, look, we need to put this stuff back in the picture.
And I will say there is also plenty of opportunity when you're at school to often pick the topics you would like to expound on, and as long as you back them up with citation. And so Power Threat Meaning Framework was one of mine that, I let other people know about.
You haven't told me that, and now you're telling everyone. I would love to see a copy. I would love to see a copy.
Absolutely. And it's the very high 5-10 minute level. Obviously can't do this justice compared to what you shared with us today, but it's a way of getting people aware that there are other possibilities out there, other choices. And I always say the bigger tent is what we should go for. Like you said, we're not saying get rid of anything that works for you, just that one thing doesn't work for everybody. So having more choices is a good thing in my experience.
Yeah.
I see another question there from Lori, asking about pure respites. Are they an effective alternative to traditional therapy?
I'm not quite sure what you mean by respites. What's a respite in American terms?
So pure respites are a peer run place you can go to kind of take time out from your distress.
Okay.
and stay
Yeah.
usually a week or so.
Yeah, we have one or two of those in the UK. Yeah, survivor run alternatives, we would call them. Yeah. Are they an effective alternative to traditional therapy? Well, I think they're wonderful places and we should have a lot more of them. I mean, depends on the place, I guess, but in the UK, they don't necessarily offer therapy as such. They're more kind of offering general support and, you know, escape from difficult life circumstances temporarily and so on. So there might well be a need for therapy as well, I guess, but not for everybody. I mean, I'm a therapist. I don't think everybody needs therapy. Life can be healing. Ordinary relationships can be healing if you're lucky. So there's a kind of implicit question about what is traditional therapy. And I mean, I'm quite cynical about a lot of traditional therapy, to be honest. In the UK, we have hugely overvalued view, I would say, about cognitive behavioral therapy. I think you probably have that in the US as well.
Yes.
And I think it has a place, and I have some training in it, and I use some of those techniques. I'm not going to dismissing it all, but in its narrow versions, it can be just as individualizing and to be honest, damaging as a kind of narrow medical model. And as I said earlier, with just the same kind of messages, if only you'd kind of sort your dysfunctional thinking out, you'd feel fine, even though you're unemployed and, you know, haven't got enough money to feed your family. You know, I think these are implicitly blaming and unhelpful messages. So we have a program of fairly narrow versions of ECT rolled out across England, and it's been going for a number of years. Massive amount of money has been pumped into it. The thing that nobody's allowed to say is that even looking at their own figures, and of course it's all sold on the idea that it's evidence-based, but looking on their own figures, it's failing catastrophically. You know, 9% of people are recovering last time I looked. Well, a natural recovery rate for the depression anxiety that this program is meant to be dealing with is something like, 50%. So it actually appears to be making people worse, if anything. You're not allowed to say that kind of thing, but I just said it. But
Thank you.
I certainly prefer a peer respite to that.
Yes. That sort of leads me into one other question I had down here, and you've sort of you've tapped into it in many ways, but it seems like when we use diagnosis and disorder that it's deficit focused.
It is deficit focused. Yeah.
So it's a deficit focused way of looking at distress. Can you just briefly expound a little more on how the power threat meaning framework can help break us out of that mold, and why do you think it's important to do that?
Yeah, well, the framework is saying the absolute opposite of a deficit-based approach. It's saying it's not in any way denying the reality of people's distress. That's another charge often get thrown at us. You're saying there's nothing wrong with people. Well, really not denying the reality of people's distress, but distress is there for reasons. It's absolutely there for reasons, and it's there for very good reasons. And it's much more appropriate, and this may sound a bit odd in a way, to give people the message, thank goodness you were able to do that, because at least it's helped you to survive and may still be helping you to survive. So if we take the example of, hearing voices, traditionally seen as a sign of schizophrenia, there's a great deal of evidence, as I'm sure many of you know, that hearing voices is a result of what you might call a dissociative response. When you, in a situation that's just too awful to bear, particularly as a young child, you may need to kind of split off from it in your mind. And this can sometimes kind of leak out either at the time or later on in the form of voices that may have some relationship to the early experience. The voice might sound like the person who hurt you or the person who abused you. Now, a deficit approach comes along and says, not only did you go through these awful experiences when you were a child, but now you've got schizophrenia. That's not a great message, is it? But the framework, along with trauma-informed practice, along with a hearing voices approach, would say, that was a very creative way of surviving. You had to split off, you had to put these memories to one side, and one consequence was you now hear voices, but thank goodness you were able to do that, and perhaps we can help you to understand and manage these voices so that now you're no longer in that situation. They don't have to dominate your life in the same way as perhaps the abuse and the abuser did. It's turning the whole thing on its head, looking at people's strengths, validating, honouring the attempts that they had to use to survive, often when there were little or no alternatives. What other alternative is there for a child other than to escape into the head, so to speak? But for many of us, the alternatives have been or were completely lacking. Very different model.
Yes. I do see at least one more in here. There may be more. Somebody says, I'm from the US and we use the diagnostic model in terms of billing our insurance, which is a major headache and barrier to accessible mental health care. Can you elaborate on how you see integration of power threat meaning framework? Whoops, I just missed it. I pushed
Yes.
up.
How to eliminate that barrier. Yeah.
Yes.
Well,
yeah.
Can I be provocative? I mean, the framework doesn't provide answers to that kind of problem. We've in chapter 8 of the main document, we've tentatively looked at a number of areas where diagnosis is still very fundamental, at things like access to services, commissioning services, designing services, access to benefits, use of medication, and so on. And we've made some suggestions. These are not formal recommendations, but research, how do you carry out research without starting from diagnostic understandings? We've made some suggestions about how you can do that. Legal systems, very diagnostically based. So, I mean, that fortunately is not a problem we place in the UK. As I said, we have the remnants of a socialist organisation, the NHS, in which access to healthcare is free for all at the according to their need. So, I mean, we have a right-wing government doing its very best to privatise and dismantle it. But I would say the short answer is you need to nationalise your healthcare system. Now, I know there have been many attempts to do that and have not got very far. That is the answer, isn't it, ultimately? But, that's US politics and to some extent UK politics. That's a big thing to get your head around. So we're left with a system that even if in the UK we don't have that kind of insurance problem, we are pretty diagnostically based. So, I mean, the only thing I can say is we have to work within systems as much as we can. So in the hospital wards I described, if you went onto those wards, you wouldn't see some kind of wonderful therapeutic environment with soft music and nobody ever using nasty medical language. You'd see very much a standard overcrowded London ward, but there's other stuff going alongside it. That's not always a very good fit, but at least there's more than one thing going on. And that has to be an improvement. But I don't think, and I think the other PTMF authors would agree with me, I don't think fundamental change is ever going to come from within existing systems. If we think about how really fundamental change comes about, and we are talking revolution in a way, we are talking about very, very fundamental change. It almost invariably comes from grassroots movements. So I think we have a need and a duty and obligation to make existing systems better and push them as far as we can, but there will be brick walls where we can't go any further. But I think really the word needs to get out, firstly, to potential service users themselves, that you do not have to accept all this stuff, and really to the general public. The general public has brought this massive narrative on a massive scale. When do you ever see a media article that even questions the existence of these medical disorders? I mean, sometimes you do in the UK, but rarely. That's where change needs to come. But having said that, I kind of see the narrative collapsing under the weight of its own contradictions. The more medical treatment we offer, the more labels we hand out, the more labels we apparently need, and the worse the outcomes are. Something is very, very, very badly wrong. We can make all sorts of attempts to shore up the model, to modify it, to add bits on the top and round the sides and deny what's happening. But ultimately, I think the model is doomed, and I may not be around to see its end, but I'm 100% sure it's coming.
And that sounds like a perfect way to wrap
apocalyptic note.
And I'm gonna thank you so much, Lucy, for everything. And thank you to everyone who's been here today. I'm gonna hand it back over to Lee to kind of close us out with some of our slides.
Sure thing. Just wait one moment while I draw those up.
And thank you to Lee very much for all the technical assistance
Thank you,
today.
Lee. Thank you, Sherry. That's all worked very smoothly.
Thank you both so much for leading such a fabulous discussion. All right, I'm pulling them up at the moment. Great. So what you'll see on screen right now is a QR code. So you can feel free to either use that QR code or follow the link. Oh, I went back. It's trying to draw me back into the framework. I'll be putting this link in the chat, and it also will open automatically at the closing of today's event. We are sponsored by SAMHSA, so this evaluation is super helpful for us to be able to evaluate, again, how well we are doing. So please feel free to let us know your thoughts about today's event. As well, you'll have the opportunity in the follow-up email to sign up for our newsletter, follow any of our social media accounts. We'll also have a certificate request form that will be in that follow-up email. So we, again, want to thank you and welcome. You're contacting us if you have any questions, the website that you see on screen, as well as the email, newengland.mhttcnetwork.org. And thank you again for attending today. Thank you, Dr. Johnstone, Lucy, sorry, I know I messed it up again. Thank you, Lucy and Cherie, for leading today's event. And we hope everyone had a knowledge and expanding great time. So thank you again, and we'll close out today's meeting.
Thank you for inviting me.
Take care, everyone. Thank you for being here. Thank you to the MHTTC as well, and Maria Restrepo Toro for supporting today's topic.
Thank you, folks.